It's 10 weeks from now. You wake up, you feel nice and fresh. You had a good night's rest last night because you didn't have to study. And you know deep in your heart that you passed your DIPIC. Welcome to DIPIC Bootcamp. It is my sincere wish that we can tell this story in a few short months from now. And yeah, as you start this journey, I want to say welcome on board. And I hope that this ultimately leads to success for you. Before we carry on and before we start, I want you to take a second or two, tap yourself on the back. And I want to say well done and congratulations for taking this big step. Writing a DIPIC is not a small thing, can be very intimidating. There's not a lot of emergency medicine physicians in the country. So if you're working in a smaller or rural area, many provinces don't have any emergency physicians. It's very often difficult to be exposed to good emergency medicine care. There are many other reasons why this is a big step for you. There are so many chapters. It's so intimidating. You've heard about so many people writing this exam. You feel lost. You don't know where to go. You maybe haven't had guidance. Fact of the matter is, just deciding to write this DIPIC is a big step. And I want to say congratulations. Well done. It's brave. I'm impressed. And I hope that doesn't matter what happens, you enjoy this process and you immerse yourself in it. So who am I? My name is James Morrow. I'm an emergency physician. I realized with shock and horror that when I wrote my DIPIC, it was 2014 or 2015. It's almost 10 years ago now. And you might be sitting there and thinking, well, what does this old geezer have that he can offer me? Is he really able to guide me through this process? Because it was a completely different ballgame when I wrote. It's changed. The amount of time you must do has increased. How they ask the questions are different. But I wrote my final emergency medicine exams, and what I can tell you is that I went through about 15,000 MCQ or single best answer questions in preparation for that. It was after that exam where a friend and I sat down and we had a chat, a friend and a colleague who wrote with me, and we realized that this type of content doesn't exist for diplomats, not in other specialities and not in ours especially. And yeah, it created an opportunity for us to share this knowledge that we'd acquired while prepping for our final exam. So yes, I might not have written a DIPIC in this iteration, but I can guarantee you I've got a really good idea how they ask it, how they ask their questions, how to approach this, what to do. I'm hoping I can share that knowledge. I hope you can jump on board and that we can pave your way to success. Let's talk about you for a second. You might be sitting there a little bit nervous. Have I done the right thing? What if? And I'm not going to finish that sentence. I think you know what I'm alluding to. And I want to tell you now that there's virtually no downside to writing a DIPIC, except for that amount of money that you pay to be able to write it. The only thing that can come from this, at a minimum, is that you become a better doctor. You give better patient care. You become more confident and competent. You know how to use all those machines. You know how to do a sonar. Perhaps you learn how to do a nerve block. Something tickles your fancy and you realize that now you can do a cardiac ultrasound that you couldn't do before. Perhaps you see a resource while we go through this and you can do something that you weren't able to do before. So really, what's the downside? You're just going to be a better doctor by the end of all of this. So embrace that. Realize that you're going to be out of your comfort zone for the next 2 months. It's not easy to study for this. There is a lot of topics. And the more you study, the more you're going to realize how much you could be studying. And the more you study, the more you're going to realize what topics are covered. And that a lot of the things we do, it's almost expected that you don't have any experience in it. I mean, how many of you have treated a snake bite? How many of you have treated a patient with high altitude pulmonary edema, lightning strikes? The whole core of emergency medicine is to be ready for anything and everything that walks through those doors. But the problem is very often you've never done those things. I still find myself after 10 years. Just the other day, we're talking about lateral canthotomies. And I told a colleague, I must admit, I've never done one. Yet someone comes in with that ocular compartment syndrome. It's expected of me to be able to perform that canthotomy. So embrace that part of this. It's writing this exam is exactly what it's like to be an emergency physician. You're going to be out of your comfort zone. It's going to be a little bit challenging, but there's no downside to this. You are only going to get better. But hey, if you're doing it, you might as well get a diploma to prove it. So the structure of the exam is going to be 2 exams, 100 MCQs each. There's going to be they're pretty much based around the concept of a single best answer. There's no negative marking. There's very few follow-up questions, as far as I'm aware, if any. It's 100 individual questions, all based on 100 different cases. Some of them are straightforward questions. You'll either know it or you don't. So patient comes in and with low risk chest pain, what clinical decision rule can you use to assist you in your diagnosis? Answer to that, heart score. If you know that, you know it. If you don't, you don't. But they will also give you clinical cases and clinical scenarios, and then based on those clinical scenarios, they will ask you further questions. So therefore, I'm gonna sit around with this for a little bit, just so that you know what you're in for on the big day. And very much the way that these questions are set up is this idea of having a stem, so a clinical scenario, clinical case, and then asking you a question around that stem. Now, that can take many shapes and forms, but I want to start off by telling you it's a good thing. It very closely mimics better than any other system I know, kind of a MCQ and a approach to a patient in one. The case has to be clear. For you to be able to answer the actual question, it can't be vague. And therefore, I want to encourage you, firstly, even now, when you read those questions, take them on face value. Don't put off that little voice in your head that's going, oh, but what if? Oh, maybe I would do this. If something is there, it's there for a reason. If something's not there, it's not there for a reason. Okay, that's a lot of waffle. Let me think of a good example. So for instance, you have an examiner who wants to set a question where he wants the candidate to consider that a lady that's old might have an MI with epigastric pain. Now, he can't set the question as the patient has epigastric pain, burning in nature, radiates up to her mouth, worse after eating. What is your next step? And then expects you to do an ECG. It won't do that. Now, in real life, we should be doing it. All old ladies with epigastric pain should be getting ECGs. But you can't paint a picture of a gastritis and almost expect your instinct to be to do a ECG. However, same patient, 75-year-old female, presents with epigastric pain, maybe a little bit of radiation up to her throat. She's got cardiovascular comorbidity, so she's hypertensive, diabetic, she's a smoker. The pain started very suddenly this afternoon. You do a bedside sonar that reveals no gallbladder features of cholecystitis. Lipase is normal. What other examination would you consider? Now, all of a sudden, you've got to think of that ECG. And therefore, again, I want you to get excited about this way of questioning, because they've got to give you enough clues within your STEM to be able to ask a good clinical question. The opposite of this is also true. So in clinical practice, we know that classic symptoms, classic triads, patients very rarely present like that. Patients just don't read textbooks, but patients who appear in SBAs do read textbooks. They do present with classic triads, with things that are seen commonly, with textbook descriptions. And that doesn't necessarily make it easy. So for instance, back to the ACS question and the heart score. So again, the examiner wants the candidate to know that for a low risk chest pain, you need to implement the heart score. Now, you can ask that in many different ways. He can say, as I said before, presents with low risk chest pain, what score? Heart score, done. Or he can present a case where a fairly young person goes to the ED. He's got no clinical comorbidities. He's got very vague, non-specific chest pain. You've worked him up for maybe one or two things and you want to safely discharge him. So again, he's got to present, if he wants you to answer a question on low risk chest pain, he's got to paint a picture of low risk chest pain. That might make you a little bit nervous, but many of those other symptoms, for instance, intussusception, they always teach you present with red currant jelly stools. The percentage of patients who actually present with that is, if I'm not mistaken, less than 20%. So in real life, you might not see that often, but if an examiner wants to paint a picture of intussusception, he might very well have a red currant jelly stools. So I hope that makes sense. And what I'm trying to tell you is you've got to embrace this way of asking questions. I think it's a very good way of asking questions. Read the question carefully, read it for what it is. Don't get caught up in the fluff. We'll do one or two examples a little bit later. Take it for what it is, and then always ask yourself, like, what is he telling me with this? Another tip that I heard is if you can, read the question before you read the stem. And the reason for this is, so as an example, you have a patient with rheumatic fever, but the way that the question is asked is that a young boy comes to the ED, he's got fever, sore throat, his tongue is red, he's acting unwell, he's not eating, brought in by the mother. On exam, you see a red tongue, inflamed throat, maybe some exudate on the tonsils, he's got lymph nodes in his neck, and this bright red rash. So you just got all this information flying at you from every area. And then the question is, what is the causative organism of the most likely diagnosis? Now, hang on. If you'd read that part first, okay, you're dealing with an infective thing. So when you read fever, yeah, you immediately start putting the puzzle together a lot quicker versus getting all this information, not knowing what to do with it. Then you're going to read the question, and you're most likely going to have to go back to start building this puzzle afresh. Now, that it won't work with all questions, but it is an approach that we all use when we wrote our final exams, and I want to give you that tip to consider doing that. And I'm hoping when you go through the practice MCQs that you will be able to practice that method, because it doesn't come intuitively and it feels a little bit strange in the beginning. But consider reading the clinical question first before you then read the STEM. Now, I know that you guys are asking me, well, what should I study? What should I prepare? I want to know the chapters. It's the same question we've been asking all through med school. And for that, I just want you to picture you are walking through a field. And as you turn to your left, this is the sight that greets you. A massive lion in the foreground, lots of zebras with some trees in the very, very far background. Now, in this field, how are you going to escape? And the answer is basically, and I don't care what anyone answers, but it's going to be formatted around this big scary lion in the middle. That's going to be your main focus. Once that has been subdued or you've gotten away, it's worth thinking about the zebras. There's a lot of zebras there, but they look pretty angry as well. But it's not going to be your primary focus. And then you're going to kind of think everything else. Now, I think you know where I'm going with this. Any MCQ must have the ability to separate the good from the bad from the average, or in our case, the safe from the unsafe. And therefore, your MCQ is kind of going to be set up in this format. A lot of the questions you're going to be asked, you're just going to kind of yawn. It's going to go, whatever. You're going to answer it, you're going to move on because it was that easy. There's going to be a subset of questions where you kind of, your heart skips a beat, start taking notice. But you know what? Maybe one or two things could have been right there, but I'm fairly happy with my answer. And then the bulk of your questions should come in this middle category where you start scratching, you start worrying. There's two or three that look really like they could be the proper answer. And you're always a little bit unsure about what you answer. And then the fourth and the fifth category, the fourth one is that one where you're sitting there and you're pulling your hair, and you know that you've maybe studied this and you've heard of the concept, but you actually just don't know what the answer is. And then your final category, and I want you to prepare from this from day one. There are going to be questions that you're going to look at and you're going to go, what the heck are they talking about? I have no idea. I am absolutely lost. I don't even understand this concept. Now, again, rest assured that when approaching this DIPEC, if you address the lion's share of the topic, the lion type topics, you will most likely be able to answer these two categories fairly confidently. That is a lot. That is a good chunk of your exam. And then when you move on to that next category, the zebras, which there's a lot of zebras in this picture, and there's quite a few of them to address. You should be able to do pretty much everything up to here. And then there are those subset of questions from the chapters that are conditions that are quite rare. Maybe it's something that's common, but they ask you a really complicated question about it. That is the reality of a good MCQ. And I can tell you that from what I've seen and heard, the MCQs fulfill this criteria. But beware, because now you go to Bob, and Bob wrote the last round at DIPEC, and you ask him, well, Bob, what should I study? What's he going to tell you? Oh man, there were all these random questions about pellagra, and there was something about a metabolic deficiency I've never heard of, and cancer. I mean, I don't even see cancer in the ED. You're going to get a fright. You're going to run back, and what are you going to go study? Metabolic things, cancer, and maybe even you go study about about pellagra. And I want to advise you from the first day is beware of that. Trust your plan. Trust the plan that I'm about to provide for you. Take these concepts that I'm going to teach you seriously, because you doctors, you're interested, you're curious, you see something you don't know, you want to run down that rabbit hole. Stick to the lion topics, the lion and the zebra topics. The other things, get to when you get there. So escape the lion, potentially engage the zebras, and after that you can go and explore those trees a little bit that were there in the background. The exam is not trying to make you a FChem emergency physician. It's trying to test whether you're a safe a safe emergency doctor who can recognize acute life-threatening emergencies, who can do a good resus, and you can take care of common presentations to the ED. The follow on from this is that if you break down those lion and the zebra topics, the truth is that the most important topics you would know are your resus type question. But if you think about it, it's not a lot of chapters you need to go through for that. And they're not very difficult chapters either. So you've got to know your resus chapters. And for just going through your ACLS, PALS, ATLS, maybe you can take it a step further and think of how you implement sonar in that. But it's not a lot of things around a resus. It shouldn't take you that much time. And proportionately, there's a lot of question that's going to come up. So it's a little bit less input, maximum results. And therefore, that's why I want to emphasize those things. And then as you go through your chapters and you start identifying, your shock patients, again, you've got your 4 different types of shocks. There's a lot of conditions that can kind of contribute and filter into that. But again, it's not the biggest array. And because shock, for instance, is such a principle-driven concept, you've got cardiogenic shock, which you treat with this medication that's maybe caused by these conditions. It's not, you don't need to put in that much time. Now, that doesn't mean you don't have to put any time at all. But again, it's good bang for your buck. That what you put into it, you'll get something out for it. And then you get those common conditions. Now, that's a little bit more difficult. It's a lot wider because again, we work in the ED. Everything can come through the door. And that fourth is quite a lot of studying, because you've got to go look for it, you've got to decide, and you might not get quite a lot of happiness for that effort, and then you get the rest, which is just everything else, which I would potentially even try and stay away from. So what textbooks are you going to use? There's some great textbooks out there. They all got pros and cons. FM, I like it. It's got all the topics in it. I think essentially the problem is just got way too many. There's a lot of topics in there that you can basically skip over, not really study. And sometimes that's a little bit difficult if you don't know exactly what you don't know yet. The Pretoria one, definitely worth getting, definitely worth having a look at. Also written by South African doctors in the emergency medicine circuit. So you are likely to get a question that was set up by one or two of the authors. And then Prof. Walter Klook's book's also really good on, again, those basic conditions, the things that you absolutely have to know. Questions will come out of those few shortish chapters in your DPEC exam. Just be aware that both of these textbooks have missing chapters. There are some concepts that I think you would have to know and learn, which are not in there, but also really good just because it's South African. It deals with a little bit of the ethical stuff in South Africa. So whatever textbook you use and whatever method you decide, just know what its pros and cons are, maybe what's being left out, and what you will need to go study up on your own. Now, if you're not aware of this, emergency medicine is basically the leader in medicine of distributing and providing free open access medical education. That's what FOMED stands for. It was 2 emergency physicians who thought about this, and I think, if I'm not mistaken, they were the 2 that started Life on the Fast Lane. And now it's a thing in emergency medicine. People have websites where all the content is freely available and accessible and is potentially accessible by anyone. Some of my favorites are Core EM. Core EM is great, nice short chapters. They're not very long. Pictures, links, videos, really, really worth going through. If you see a topic there that you think is important, go and read it. EM Docs, also great. They've got a series called EM at 3 a.m., which is the same concept, shortened versions of topics, nice to the point, things that I think a diplomat would know. Some really amazing longer articles as well. And when I say articles, not academically written articles, it's basically like chapters in a textbook. And can highly recommend that you go through it. Just be careful of not being caught in those really, really long chapters and not getting to the important stuff. Life in the Fast Lane, brilliant. Very, very dense. There's actually too many topics on Life in the Fast Lane. It's very difficult to navigate around Life in the Fast Lane. You don't know exactly what you're looking for. In cases, they have great podcasts, 2-hour-long podcasts. So you got to know what you're letting yourself into, but with show notes that almost reads like a beautifully written chapter. The small issue with it is, again, the risk of spending a little bit too much time on certain things. Use those podcasts. There are so many emergency medicine podcasts out there. And then YouTube has got a great series called EM in 5. The name of the lady that made them, or the doctor that made them, escapes me. But very good, nice summarized videos of certain chapters. Beware with all of these online resources that it's very much written or driven by a person or a few individuals. So there might be some subtle mistakes here or there. They are mostly from the first world, from the West, and there are a couple of drugs and medications that are not quite the same of us, but the principles remain the same. They are good websites, they're great resources. I almost exclusively studied for my FChem on these online resources, and a few more that may be a little bit more complicated. But really, really, the resources are there, they're available, and yeah, get excited, because it's emergency medicine that does this. It's a really, really nice broader community to belong to. Now, I won't lie, at this point, you're probably feeling like you're drowning. I mean, I've recommended 3 textbooks, 7 websites. It is very, very scary. So like any emergency medicine presentation, you need to have a good approach. And I'm going to give you a very rough approach, or what my idea, or what I would do. But that's me. And you need to do that, and you've got to make a plan, and you've got to stick to your plan, and trust that your plan will work. So I almost want to say it's a non-negotiable. ACLS, ATLS, PALS, anything that involves a resus, you've got to know word for word and back to front. And it's not a lot. You can find beautiful resus algorithms on the Resus Council of South Africa. That's at RCSA. You can Google it. You're going to recognize the posters. A lot of their posters are available in EDs around South Africa. Really have done great work in the resuscitation sphere in our country. Yeah, and that's just something that you have got to know. And it is almost guaranteed you're going to get a couple of questions on that. Not a lot of material to cover, but yeah. And then after that, you're always going to ask yourself, what are the things of the life and the limb threats? I would say that's kind of the halfway between the lion and zebra, because some of them are super lion topics. Maybe other ones are in your zebra topics. But yeah, you got to know those topics well. Common problems, common presentations. Definitely worth going through that. That would be my 3rd tier. And my 4th tier would just be to ask myself, well, if I was setting up an exam, what are some of the things that I might potentially ask? Not that easy if you're not in the emergency medicine kind of environment, but it does help a little bit. So, I mean, for instance, it's a lot easier to make a question that says patient presents with these 3 symptoms. Those 3 symptoms belong to a classic triad. What would be your next management, versus a thing where you're trying to paint a picture of what a patient has. So now you've got to think about the last meal and what effect that had, and this is what it did then, and this is exactly how the abdomen feels, and think. What I'm trying to say, that if you see something classic triad, learn that classic triad. If it's a clinical decision rule that's very applicable in the ED, you got to know that clinical decision rule. Sometimes you've got to know it word for word. Sometimes you've got to know just that it exists and that you can use it in that scenario. But yeah, just ask yourself if you can spot things. And that's the thing that I'll write down on a piece of paper, maybe keep a document on your computer where you need to have a little bit of a spot list at the end. Those are the things that I'll quickly go through, and hopefully you can score yourself a couple of points. So for instance, what I did here is I took a picture of all the chapters all the chapters in the cardiovascular section of the FM, and I kind of divided it into these lion, zebras, the trees in the back, and the naughty spots. Now, when I talk and when we do the material in the course, I might say this is less important, this is more important. I'm not, don't worry, I won't be talking about lions and zebras the whole time. But what I do want to tell you is that just because I say something's less important, or maybe I wouldn't study it, does not mean they might not ask it. Anything can come through the door, remember? But the truth of the matter is acknowledgement that there are certain things that are more likely and more probable to come up. So this is my list. It's based on purely my opinion. It's kind of how I would approach this if I was studying for the DIPIC. So as you go through these topics one for one, dysrhythmias, bradycardias, tachycardias, AFibs, hypertensive emergencies, ischemic heart disease, and PE, they are so kind of ingrained in being an emergency physician that just on that little list, I mean, I'm talking, and I'm taking a chance by saying this, so I could be wrong, but I think 50% of your cardiovascular questions are coming from that Lions list. I mean, they've got to ask you something about, they're going to ask you something about ischemic heart disease. This is highly likely they're going to ask you stuff about pulmonary embolism. Then a couple, I mean, AFib is so common. It's just, you know, it's just being able to identify that and then having the guts to kind of move on from it and then study the next chapter and then telling yourself that by the end of it or when you have time, you'll go to the kind of the trees in the back type topics. Then the zebra topics. I think if you do the lion and the zebras, I think 75 to 80% of your questions will come from that. And again, you're looking like something like pericarditis, your cardiac tamponades, acute cardiogenic pulmonary edema, AAAs or aortic dissections, and your DVTs. Yeah, so look, the difficult thing about this is then knowing to say, right, those are the topics I'm really going to focus on. I will maybe quickly read through the others. Now you read through these topics, you read mitral valve disease. It talks about murmurs. I mean, you tell yourself, you've never done much with the murmur in the ED. So they probably don't, they're not going to ask so much questions about it. Even something like an acute valvular emergency. It is an emergency. It's very life-threatening, very poor prognosis. So therefore, you might go through it. But, if they're going to ask you a cardiac emergency, is that the one that they're going to be asking you? But as you go through this, you see the word rheumatic fever and you see Jones criteria. Now, if I'm setting up an exam, that is very low-hanging fruit. Couple of pictures. You can paint a nice clinical picture around it. It's got a very classic type presentation. So even though you're not going to study everything in valves, you might, on that little spot list that you've created, you might put Jones criteria. Does it mean they're going to ask it? Well, we don't know. But you know what? It's worth just going through at the end. Something like myocarditis. When you read through it, you'll see, I mean, very vague, nondescript, is very difficult to diagnose, very difficult to, there's not really, in the ED, we're suspecting it, and then we're referring it. That is basically myocarditis summed up. You might see in there the most common causative factor for it, the most common virus, and therefore you're going to maybe write that down on your spot list. But what I'm trying to tell you is don't spend a ton of time on myocarditis because you're interested or because it looks interesting. The chances are just they're probably not gonna ask it. And then something like another one, and I see I didn't actually put it in here. There's congenital heart diseases at the bottom there. Now again, there's a lot of congenital heart disease. Are you going to know every single one of them? Are you going to know the features for tetralogy of Fallot, ASDs, VSDs, Eisenmenger syndromes? Are you going to really sit down and learn every single one of them? But if you're in the EM community and you kind of keep an eye, the one thing that they want you to know is TET spells. The likelihood that they're going to ask you TET spells is far higher than they're going to ask you any one of those other things. So although you're not going to study the whole chapter, or you might quickly read through it so that you got a bit of an overview, it's the TET spells that you're going to focus on in the end. So that is kind of the thinking and the approach that I would do as I go through this section by section. And it is difficult. It is quite intimidating, especially again if you haven't been in those emergency medicine circles, to be able to identify the most important topics that you need to cover. But luckily, there's a really good resource. I would highly recommend that you follow this impact frequency kind of table that they have on the College of Emergency Medicine website. It really does paint a good picture of the most important things that you need to study, the likelihood that it's going to come up. And as I said, these exams are moderated quite well, and they do follow that. Now, in retrospect, you'll often think that they haven't, but I can guarantee that if you went through your exam and you measured it up to this, you'd find that they pretty much stick to it. So if you struggle, if you don't know where to start, and it's difficult for you to identify what you think is important or not, this is a great place to start. And I really would use it as the backbone of my studying plan. So you might be tempted to ask, should I study this? Should I study that? Please don't message me that. My answer is going to be the same every single time. They might ask it. I can't tell you no. There's nothing that can't come through the door. but rather ask yourself, what is the likelihood that they're going to ask us? This paper's been set up by emergency physicians. They know what things are common. They know which conditions appear in our departments most often. So a better question to ask is than if I should study this is to just ask yourself, what is the likelihood that they're going to ask this, and trust your gut, stick to that, and focus on those lines. So we're going to focus just on a couple of examples. As I said, when you answer your question, there's a little bit of an interplay sometimes between what you would do and what they're asking. I'll show you in an example now by what I mean by this. Stay calm. Take the question for what it is. Don't overthink it. See it for the black and white that it is. Don't try and find things that just aren't there. So to put all of this together, let's do two practice trauma questions. This is kind of the type of question that they're going to ask you. You have a 26-year-old male. He presents after an MVA. He's making gurgling sounds. Only one side of his chest is moving. He has a simple laceration on his leg. He has an unstable pelvis and an obvious femur deformity. He's shocked. His BP is low. His pulse rate's high. His sats are low. What is the most important initial management? So interplay between what you would do normally and what they're going to ask. So what are they asking? What is your first step? And what they are testing is whether you can follow ATLS principles. In real life, you're probably going to assign a team. You're going to be 4 patients around the bed. Someone's going to be taking the airway. Someone's going to be putting in an IC drain. Someone's going to be fixing the femur. Someone's going to be fixing the pelvis. But what they are testing is whether you can prioritize those steps. So what is the first thing you're going to do? And the answer is A, nothing else. Because we are doing trauma. The first step in trauma, or with any emergency medicine patient for that matter, is ABC. Okay, so the thing that this person needs is some form of airway intervention. Does he need a finger thoracostomy? Absolutely. He's got features of a tension pneumo. Does he need direct pressure to the bleeding wound? Probably, but remember, it's not something that's going to kill him. So that's almost right at the end of your management. Jaw thrust to open airway. There we go. There's our airway maneuver. A track 3 splint to apply traction to the femur fracture. He needs it. It's part of your C. And then an EFAST to assess for free fluid, also part of your C. So what is the most appropriate initial management? You need to do a jaw thrust to open the airway. So again, don't overthink this. They have deliberately given you a bunch of pathology. They want to test if you can order it. Because remember, that's why ATLS was written. It was designed for someone who's in a fairly low resource community, resourced environment, where the order of what you do is so important. Now, as you read this, turn off that voice in the back of your head that goes, oh, I'll do this together. Or maybe I'll quickly do the ICD. He is gurgling a little bit, so maybe he would be able to survive until there. Or maybe you even think, well, if I intubate him or do airway things or apply BVM, it might make the pneumothorax worse. Quiet that. This question clearly says he's got an A, B, C, D problem. Which one are you going to do first? And in trauma, the answer is always A. Now I'm going to follow that up with the next question. So you have a 27-year-old MVA, it's high velocity. He was intubated on scene with rocuronium. On arrival in the ED, he's noted to have equal chest rise and air entry when EMS personnel bags the patient. On arrival, he's imaged using a Lodox. You note the ET tube is well placed and both lungs are fully expanded. Two 18-gauge Jalcos are in situ and his ring is lactate running. Once you see the patient, you note that he has an unstable pelvis and an obvious tibial fracture. The affected leg has no dorsalis pedis pulse. What is the most important next step in managing this patient? Next step. In real life, if an EMS person comes to me and he has intubated the patient on scene, even if I can see chest rise, even if an X-ray with the Lodox shows me good placement, I'm probably going to be doing some form of airway assessment just to make sure. But this question has specifically told you that there is good and equal air, chest rise and air entry, as well as fully expanded lungs. So what is this question telling you? That A is fine, B is fine. You accept it, you don't argue with it, you turn off that voice in the back of your head that goes, oh, but what if this, what if that? Just read the question for the black and white that it is. So what would you do in this case? Okay, Are you going to order a pan scan with angiography? You are going to do that eventually. It's one of the things that will form part of his management. Recheck the placement of the ET tube. You'd be very tempted, but the question has made a point of telling you that the ET tube is in place. So it's not that. That's not the correct answer, even though it probably is what you might do. Do a log roll to assess for all injuries. That falls under E. Attempt to reduce the fracture. You might be very tempted to say that because a limb with a threatened pulse needs to be addressed. Or bind the pelvis. Binding a pelvis is part of your C in the ATLS protocol. So although in a sense you're probably going to be doing all of these steps in the scenario that they've created, the next best thing to do is you're going to be binding the pelvis by following and that's because you're following good ATLS principles. So those are just some of that. It's just two quick examples. Hopefully when we address the MCQs a bit later on in the course, we'll get back to some of this. But I just, again, to reiterate the point, read your question, take it for what it is, turn off the voice. And most of the time you are going to ask yourself, what would I do in this case? Just also query, does that fit in with the question? I hope that makes sense, and I hope I'm trying to get my point across. It is a little bit different, and it's sometimes, because we always want that thing where we say, oh, but what if this? On a ward round, when a doctor asks you a question, you always kind of give an answer that can be summed up. Well, it depends. Maybe this, maybe that. Let's explore this option. Let's consider this. In this case, they are giving it to you as if the patient read his textbook, and those are your findings. Don't fear normal findings. Remember, that's very much part of our job. If something is normal, and for you to be able to identify something as normal, you've got to study what normal looks like. So don't try and make things fit. Don't make round holes fit in square pegs. Read your question, look at your pictures. If it is normal, go back to your question and ask yourself, well, does this all fit together? Could this be normal? And if the answer is yes, don't fear a normal investigation. There are many, many different things that they can ask you. They could ask you, what organism causes a certain infection. They can paint the picture of that infection and then ask you what organism paints this. They can ask you about clinical decision rules, what the next best step is in the management of the patient, what the best step is in managing the patient, what a definitive treatment or a definitive intervention is, what the contraindication of a certain intervention is. I mean, for instance, with a contraindication, they paint a picture of an MI, central crushing chest pain, that doesn't get better with multiple doses of morphine. What is the contraindication to giving this patient a nitrate? And then the answer would be your inferior and posterior type MIs. Sorry, inferior and your right-sided MIs. Yeah, so many different ways that they can ask. They can ask you straightforward, what is the diagnosis in this case? But then obviously they're going to have to paint you that nice picture in the stem. So the type of questions they can ask, endless and boundless, but it will pretty much always be in the format as we have discussed. So what am I going to try and do on this boot camp is apply the principles that I've just described to you. For most of it, what I want to do is highlight the topics and the issues that fall within these bottom two categories. That will be where the bulk out of most of what we're doing is going to come, to highlight the things that are important, to focus you on those zebras and the lions, to highlight topics that perhaps you wouldn't have thought of before. I want to give you a chance to practice these MCQs so that you can get used to the format that they ask at. But that is essentially what we are trying to do. We want to get you to pass this. And in order to pass this, I've got to put my money in my mouth. I've got to believe in what I just said. And it's to provide you with the resources and information that you need to knock these two categories and most of these categories, or most of this category out the park. So you can almost guarantee that pass. Now, that doesn't mean as I go through things, I might not do a few complicated concepts. I might highlight some things that I would study just because I think it might be a good spot. It doesn't mean that I'm going to completely ignore the rest, but I would be foolish to be spending a large amount of time in this category and ignoring all of this. So that's really what I'm going to be trying to focus in on this boot camp. The way I see it is that I'm going to try and provide you with resources, even more resources that are out there. And sorry, that's another thing, is to highlight, where you can maybe study this, where you can look at that. Everything that I recommend should be freely available on the internet. And hopefully you can use that as a little bit of a guide to know what to study. Now, my suggestion, what I do, you've got the release dates for when all the recorded lectures will be uploaded. Maybe consider structuring your studying for the next about 8 or 9 weeks when we're going to post this video around those release dates. And so that in that week, maybe you're just doing trauma and maybe a little bit of review of something else. When the video comes up and you see something, hey, but I haven't studied this chapter, I haven't done that, then in that week you can go look at that. That's a week you're going to be listening to those trauma podcasts in the morning. If you've signed up for this, I'll make those playlists available. And so almost put your preparation into those weekly blocks. Now, that doesn't mean that's what you just got to study. It just will be a lot easier to do that while following along with the uploading of the recorded lectures. On that, what to expect from those recorded lectures, they are very, very intense. The biggest part behind this, so I mean, if you do a trauma recorded lecture, for instance, it's very difficult to put all of that content into an hour and a half. So I've had to take a few shortcuts. There is a lot of pathology and there's a lot of things that are in there, and therefore I can't spend time. So if we, for instance, examining a injured chest and we're asking ourselves, well, what diagnoses are we considering? I can't talk about the bruises that you're going to see, and you maybe have a few fractured ribs. So the assumption that I've made with all of them is that you all got good basic med school intern ComServe level knowledge. And a lot of it's more about highlighting that this is an important chapter. This is what you got to do. At the same time, though, I don't want to just make lectures that are all orientated around the exam. I want you to be able to see and imagine cases. I want you to be able to implement in real life. And that's the balance between the two that I've tried my best to implement. So that doesn't just me sitting there going, and then I will study this, and then I will study head injuries, and then I will move on to C-spine. I mean, you won't be able to listen. But what I need to tell you is those lectures are going to be intense. It's going to be fact upon fact upon fact. If you need to pause a video, maybe go look at some of the content separately. Maybe that's when you're going to approach another resource. It's been developed with those kind of two approaches in mind, to try and get to highlight those important the zebras and the lions and a little bit of the trees over perhaps doing a thorough full lecture. So for instance, if we're talking about clavicle fractures, I mean, yes. Am I going to talk about mechanism? Probably not. And I'm going to leave that out because, again, in an SPA, it'll be straightforward. He's been struck somehow on this part of his arm, and therefore I don't think it needs to be in a lecture. Am I going to say about neurovascular exams? Often not, because my assumption would be, and perhaps we'll cover it in the beginning of the lecture, that that any fracture, you need to assess a neurovascular exam. What I will tell you are what are the indications for surgical referral to an orthopod and which patients can be discharged. Because my feeling is that might be the question that they're going to ask you in the MCQ. I don't know. I don't sit on any boards. I've got no conflict of interest in this. So I can't say 100%. But for instance, that's why, in order for me to get as many topics into the lecture, those are some of the liberties and some of the shortcuts that I might take. And I think that clavicle fracture is quite a good example. I will give tips as I go. It is my opinion. Everything we do is my opinion. And I'll highlight that in the recorded lectures. The live lectures, very much, there's a lot of debate whether we're going to do it or not. They will be a little bit slower. I will take questions in there. There's at the moment, when we recorded this, quite a lot of interest. So we still got to figure out a little bit. The questions might be written questions that need to be typed while I talk. Again, the idea is to get you guys through as much content as we can. My suggestion for all of them is to have a pen and paper with you, because I'm going to ask questions, but I'm never going to ask someone to answer. And that, my friends, is because when I was a student, I hated when people asked me questions on a video format. I just didn't like it. So therefore I don't expose other people to it. But when I ask something, write the answer down and tell yourself, oh, I got this right or wrong. The best thing for you to do in that case is to get it wrong, because then I've got to brush up on my knowledge a little bit on this. It is also a nice idea to feel like I am engaging with people a little bit. If I had my way, we'd all go away for 3 weeks and we do in-person lectures. I far would prefer that over a video format. And yeah, we'll see how it goes. All the live lectures will be recorded as well. We'll upload those as well for the people who can't attend that. But they are going to be very similar to the recorded lectures. It just would give you those opportunities to interact. They are going to be a little bit more orientated to the more visual type of topics, so X-rays and orthos, maybe a couple of ECGs, ENT, derms, that type of thing, eye emergencies. And it's very much because what you need to know for exams is actually quite short, and you need to identify it, which is the most important part, and then you and yeah, maybe need to answer one or two final questions. And then the final weekend is very much up to you. That's a weekend where we're going to do 6 hours of, I'm going to be available online to take questions. From my side, I will have something prepared for every single one of those, so that if there are no questions, then we can maybe cover some last minute spots, some last minute key focus areas to land the certain areas that are not that maybe you haven't studied yet, or you need reinforcing. These lectures are not going to be available afterwards. It's deliberately, we set it up a week before the exam. I have seen in previous people that I've helped with DIPIC that last week of the exam, I must be out of the picture. You need to focus on putting it all together, taking all the resources as they were available, and yeah, putting it into that last week, which I hope you guys have all got leave and you've taken some time that you can use that week to prepare. But I'm also open to suggestions. It is up to you. I will still send out a form of things that you want covered, things that you want done. We'll make that. We'll put a lot more of that in your hands to hopefully get you through a couple of things that need reinforcing. I will tell you if I think something is not worth discussing. If you ask me some fancy question about some fancy procedure, yeah, there's no point a week before and to be dwelling on all those things. It's going to be all about focused, getting you through that DIPIC. I've tried to set up these questions as close as possible to the DIPIC. This is based on research, talking to people. I'm pretty sure I've got this right. But if anything, it'll give you a platform to practice your MCQ questions and to see and to get used to this SBA kind of approach to asking questions. So everything in about this course is about building that foundation. We put it on our sign up form. We cannot guarantee you a pass if you attend this course, but it really, I think, will give you a solid foundation to work off. It'll highlight the things that you need to know, and it'll give you enough to build off to set yourself up for success. So I want to take this final slide to just say that I really am grateful for the opportunity. I'm taking it very seriously, and I've left some good news for the last slide. Everything that you guys are signing up for and everything that are on our pamphlets is the absolute bare minimum that you will be receiving, especially in that category 2 and 3. Every single lecture we do, I'm going to upload show notes or lecture notes, which will contain all the online resources I used to set up those lectures. So if you need a little bit guidance about the online websites, I promise that I'll do everything in my ability to give you guys the best resources and the best chance of passing this exam. I'm going to try my best to upload lectures earlier than what we've promised. We've set ourselves those deadlines as kind of worst case scenarios. It takes a long time. We haven't done all of them, but the ones we did, it takes me about a week to put together one presentation. Because of that, we're trying to get through as many of the important topics as possible. So we touch on at least a little bit of everything as we go. But I'm going to endeavor and I'm going to try my best to get those out to you before the promised dates. If that is done, I will look at additional ways to start assisting you. But I want to say at this point, the risk that I run, and I'm happy to admit that, is that I might give you too much. And that can be worrying, because as I said in the beginning, the thing about emergency medicine is the more you study and the more you know, the more you realize just how much there is to study and know. And I don't want to add to that burden. So that plan that I made is that I'm encouraging you to make that central skeleton plan. Stick to it. Back the way that you have used to study in the past. If it brought you success in the past, if it ain't broke, don't fix it. And then as you have that plan, use the resources I provide, use the resources that are out there. And that combined with what I will provide you, hopefully in 2 weeks, in 10 weeks time, you'll wake up in the morning, you've had a good rest last night, and you'll know that you've passed your DPIC. Guys, I'm looking forward to it. Sign up for the boot camp. Let's get this ball rolling.